I'd like to invite Dr. Janavicius to start this presentation.
Thank you. Good morning and welcome all of you. Can you hear me well?
Yes.
Okay,
yes,
so I just need to share my presentation. Can you see it as well, right?
Perfect.
Okay, so the title of my presentation is Clinical Utility of Germline Prostate Cancer Genetics for Disease Management, and I will focus mostly on hereditary prostate cancer. There are several potential disclosures and conflicts of interest. However, the content of this presentation is not influenced by these things. From the genetics point of view, all cancer can be divided in three main parts. So one part, which corresponds roughly about 5 to 10% of cancer, is called inherited or hereditary. And here we have germline mutations in known cancer predisposition genes, either high risk or medium risk. However, for disease to develop, there are obviously additional factors unnecessary, and most of them come from environment, and that's why we very rarely see a complete penetrance, so-called, of cancer risk. So the penetrance means the risk. So most of these cancer predisposition genes are not full penetrant, so the risk is significantly lower than higher proportions. The next type is called familial cancer, which corresponds roughly to 20-30% of mutations. And here we have multiple genetic variants in various genes, or even in non-coding areas, such called intronic spaces or places. And here we have mostly see just aggregation of cancer without any particular pattern. For instance, in previous example, we usually see autosomal dominant inheritance with 50-50% of inheritance. Here we cannot see clear pattern, and there is kind of intermediate balance between genetic and inherited, non-inherited factors, and that area mostly comes from polygenic risk scores, which is still in early stages for the implementation in clinical practice, so-called polymorphisms. And the major type of cancer is obviously sporadic. So here we mostly talking about non-hereditary external risk factors. Classical examples would be, for instance, lung cancer due to smoking, or cervical cancer due to HPV. However, the genetic factors obviously are important here as well, but we probably do not understand them well in this area till now. So the next part of my talk mostly concerned hereditary cancer field, and it's very and even crucially important to distinguish hereditary and sporadic cancer at the molecular level. And here is quite simple representation from Swedish scientist Natson in early 80s. which shows the main difference between these two types. He derived that model after studying retinoblastoma tumor. However, it can be applied in all cancers. So here we can see chromosomes as vertical bars. You probably recall we have 46 chromosomes, or 23 pairs. 22 of them are autosomal. The one pair is called sex chromosomes. So here one pair of chromosome is inherited from mother, from maternal side, and the other from paternal side. And since and obviously they have two versions of each gene. Currently, it's estimated we have about 25,000 genes. So all genes come in two versions or alleles. And in the case of sporadic cancer, initially from zygote stage, all chromosomes or genes are normal, so-called, and after the course of life, in single, let's say, initial cell, somatic cell, spontaneous mutation happens, and that's can be regarded as initial trigger factors for some other cascade events, and only after the normal allele is inactivated by the other mutation, here we have malignant phenotype, and obviously there is a cascade progression, and we are dealing with these types of mutations while studying biopsy material or post-surgical material, and specialists who are involved are our colleagues pathologists, also all treating clinicians, surgeons, and medical oncologists. On the other hand, in the case of hereditary cancer, from the initial stage, it is from zygote stage, we have a maternal, and all nuclear cells will have initial mutation. So statistically, it's far more usual that any cell will acquire inactivation of another so-called normal wild-type allele, and after that event, here is be another cascade of molecular events which leads to malignant phenotype. And if we see on y-axis time, it's obviously that progression of inherited cancers is faster than sporadic, and that's main of the explanation why we usually see slightly early age of onset in these types of cancer. And here we test so-called genomic or germline DNA. So traditionally we're using leukocytes DNA or saliva leukocytes DNA, and since we are dealing with inheritance, here we come as clinical geneticists in this field. And obviously, after performing somatic profiling, testing of tumors, inevitably we can identify potential germline events, and therefore it's very important to refer to genetic counseling if somatic mutation in the same genes is found after tumor testing. Approximately 14% of men will have prostate cancer in their lives, so it's so-called general lifetime risk of prostate cancer with several risk factors with the age domain important, and there is predisposition of family cancer history as well as genetics as well. And it was known for a while very strict criteria for identifying hereditary prostate cancer, which was developed before even BRCA genes were identified, and it mainly encompassed family history, as you can see, also disease of onset. So there must be prostate cancer in 3 generations, 2 cases at least 55 years or earlier, and 3 or more first-degree relatives. Currently, while we are talking about cancer as complex disease, again, for all types of cancer, of so-called common cancer, we can apply U-form curve, which relates the variance frequency, or previously mentioned genetic allele frequency in population, and risk. So in Y-X you have effect sites or actually genetic risk. So here on top you probably have kind of 100%, which is very unusual. Maybe in the adenomous familial polyposis, you will have such kind of high risk, but it's very unusual. On the other side, you will have, and here you will have very rare variants, and on the other side, you will have very common variants in populations. More than, for instance, 40% of all having the same polymorphism, for instance, who individually have very tiny effects. However, after the summing of all these effects, we can have quite significant polygenic risk scores, and that comes from so-called genome-wide association studies, which are performed more than 15 years altogether. So in a successful presentation part, I will mostly talk about intermediate variants or mutations, because very large risk, high risk variants are still not known. Probably they could be found. We don't know, because they could be potentially very rare, and with the advancement of technologies as well as expansion of international collaborative studies, it can be identified. So currently, mostly in clinical practice, dealing with intermediate risk size alleles or variants. HOX13B was the first actually prostate cancer specific gene, which was identified in 2012, and it was found most frequently in Scandinavian populations with 0.2 overall distribution, and man with this variant has 62% absolute prostate cancer risk versus 15 of non-carriers. However, this variant hardly used in clinical management of this disease, except only for risk evaluation. And actually, as I mentioned previously, the same current situation is with polygenic risk scores. However, the situation might change in following years, because a lot of studies are ongoing with translation of this information to clinical practice. here is one of the first study which showed multiplicity of hereditary cancer, prostate cancer, and here were shown, they found various germline mutations in various cancer predisposition genes. More than 35% corresponded to BRCA2 and BRCA1 genes, and which are, as you probably know, relates to hereditary breast ovarian cancer syndrome. Also, there were some other moderate breast or ovarian cancer genes, such as BRIP1, ATM, for instance, PALB2, also CHEK2, which also is involved in twofold cancer risk increase in female breast cancer as well as colorectal cancer. This MYH gene is responsible for specific autosomal recessive type of adenomous polyposis, and it's actually quite unusual finding with this prostate cancer. And PMAS2 gene comes from Lynch syndrome gene families, so-called mismatch repair genes. So there were some initial attempts to find out the larger picture of this hereditary cancer. This station profoundly changed in 2016 after a seminal study where around 12% of advanced metastatic prostate cancer were found to have germline mutations in DNA repair genes, with top gene BRCA2. So there are some similarities with other study, and here you can see the proportions of variants, so-called pathogenic variants or mutations we usually call in these types of cancer. So after that study, some other similar findings were found in from other research groups. However, there could be some selection bias, especially for BRCA genes. And also important to know that about 5% of all cancer, localized cancer, also harbors mutations in germline genes as well. So currently, the estimation is that about 16 or 17% of all prostate cancer can have a germline pathogenic variant, and that's data from a quite large study from US group, where they found that about 17% of men with prostate cancer, which were unselected for family history or stage of disease, also age diagnosis, had positive germline variants, and 30% of them were in BRCA1 or 2. And again, the top is BRCA2 gene. And currently, there is more or less agreed list of so-called germline genes which have elevated prostate cancer risk, which are similar from the other slides. And we can regard as BRCA2 gene as main prostate cancer gene. We know that the prevalence of germline pathogenic variants in BRCA1 and 2 genes is about slightly higher than 1% for all prostate cancer. before 65 years, and 4 to 5 times higher in metastatic castration-resistant prostate cancer. That was known for a while that male relatives in breast cancer families have 2 to 3-fold increased risk for prostate cancer. And currently estimations are that germline pathogenic variants in those genes, so BRCA1 and 2, increase 3 and 7-fold respectively prostate cancer risk. However, there are quite wide range of relative risk in various studies, because they come from retrospective studies. The 4 prospective studies are very important for identifying more precise risk estimation, and that was recently published by K Group. They estimated large cohort of BRCA1 and 2 gene mutation carriers, and found that absolute prostate cancer risk for BRCA2 carriers goes to till 60%, till the age of 85, and for BRCA1 that would be about 30%. And also they found a significant association with family history of prostate cancer, where you have a higher risk, even higher risk for those patients who have family history of prostate cancer, as well as for BRCA2. There was significant finding of localization of mutation, because that was known for a while. Particular places, region in BRCA2 gene, so-called ovarian cancer cluster region, which was identified from breast ovarian cancer studies. It actually is like a central part of gene. And here we can see inverse correlation of the mutations localized. Mutations which falls into this ovarian cluster region actually has very low prostate cancer risk. However, on the contrary, the mutation which do not involve this cluster have significantly higher prostate cancer risk. And here some tabulated data which are quite important for risk counseling in clinical practice. Just to remind, for some of you, hereditary breast ovarian cancer syndrome. So two genes, BRCA1 and BRCA2. BRCA1 gives about 65 to 45 risk increase for female breast cancer. Also, about 40% increase for secondary primary breast cancer. Also, about 50% of ovarian cancer. And again, I will draw attention to a wide range of risk. And here we have obviously for higher rates data coming from retrospective studies, and for slightly lower from prospective studies. So usually in clinical practice we use approximation, like average risk about 70% or 40-50. Again, men have about 2-fold increase prostate cancer risk. The other station for cancer risk is seen in BRCA2 gene. So quite similar female breast cancer risk. However, predisposition is mostly to later age of onset, after age of 50, but it could be before as well, and a significantly lower ovarian cancer risk, which is mostly also increasing slightly at later age than BRCA1, let's say 40-45, where for BRCA1 you will have risk increase from 35 years. And here we have increased male breast cancer risk as well as prostate cancer, which was known, showed from previous studies and slides. Also, there is a slight increase in melanoma risk, as well as pancreatic cancer for those patients. Also, it's known that BRCA2 associated prostate cancer has poor overall survival, and here you can see the differences of Kaplan-Meier squares for BRCA mutated patients versus non-mutated patients. And it was found that BRCA2 associated prostate cancer is more aggressive, and actually this finding is in line with higher germline mutation prevalence in metastatic prostate cancer. Recently, European Medical Agency approved PARP inhibitors for metastatic castration-resistant prostate cancer with germline or somatic mutations in BRCA1, 2, or ATM genes, and this approval came from a profound study where significant overall survival was demonstrated in those patients receiving olaparib, and most significant effect was for BRCA2 gene, as well as ATM and BRCA2. However, no significant effect was found for other genes involved in so-called homologous reparation system. However, the data were quite the number of cases was not so high for the statistical estimation. The other study which came from US was TRITION-2, which led to approval of the other PARP inhibitor called rucaparib. I would like to briefly remind or explain recommendation, the involvement of PARP and inhibitors. Normally, in the cell we have several DNA repair systems, and PARP is poly-ADP repose polymerase. So it's an enzyme which is responsible for single-stranded break repair, so-called base excision repair system, where this enzyme detects single-stranded breaks and repairs. If we inhibit this enzyme with synthetic analogs, so-called inhibitors, actually all uncorrected single-stranded repairs are converted to double-stranded repairs. And for double-stranded repairs, there are other systems which are involved in the reparation, and all these systems called homologous recombination, BRCA1, 2, ATM, and other genes are involved in this system, so-called homologous reparation genes. And where we have germline mutations together with somatic mutations, we have completely inactivation of those genes, and if we inhibited PARP in those cells, they simply do not. They experience very high genomic instability and cannot proliferate. Therefore, enter into apoptotic state and program death. However, cells which have intact one allele, so for instance, all these other cells with germline, just single mutation, they can repair these breaks and survive. Therefore, we rescue normal cells and target only cancer, specifically cancer cells. And that principle called synthetic lethality, mostly due to synthesis. So all of these systems acting together. So that's Latin name of this phenomena. FDA also extended the genetic test for prostate cancer for an expanded list, which can be tested to prescribe PARP inhibitors. As you can see, there is about 14 genes involved in this homologous repair pathway. From the recent ESMO recommendations, the list is slightly smaller of genes which should be included, but it's minimum, I would say. So you can find PIC1 and 2, PTEN, ATM, PALB2, and others. Also, if somatic mutation is found in tumor, patients have to be referred to germline testing, irrespective of family history. Also, you can see microsatellite instability tumor testing. This concept comes from Lynch syndrome because it was very, and still is a very useful marker for screening of potential inherited so-called non-polyposis colorectal cancer or Lynch syndrome in mismatch repair genes, the other DNA repair pathway. However, as you probably know, it was found that specific targeting of checkpoint kinases with specific inhibitors, PD1 or PD-L, can act as potential enhancer of tumor immune response, and therefore these inhibitors like pembrolizumab is approved for the treatment of MSI high called prostate cancer, as well as other cancers, where there is no alternative treatment options. And also current ESMO guidelines extended the germline testing for BSC and other DNA repair genes, and recommends testing in all men with advanced prostate cancer, regardless of tumor feature. So regardless Gleason score, which was previously regarded as 8 or more, so it's not very important now. Also regardless family history. Also for men diagnosed with localized prostate cancer who have at least 2 close relatives on the same side of family, either paternal or maternal side, with various tumors which link to hereditary cancer syndromes, and the list is quite extensive. And the last slide for screening, so also from ESMO guidelines, Early prostate cancer is recommended for BRCA1 and 2 carriers from 40 years of age. Also, presumably for other genes involved in the same pathway. And to conclude my talk, so there are several conclusions. The prevalence of germline DNA repair genes mutations in prostate cancer is relatively high, 1 in 6. The prevalence of germline mutations is higher in metastatic prostate cancer. BRCA2 is the main gene for inherited prostate cancer. BRCA2-associated cancer is more aggressive. After somatic testing, tumor testing for therapy selection, all identified cases should be referred to genetic counseling due to potential germline pathogenic variant, and germline testing criteria are expanding currently for men with prostate cancer. So thank you for the attention.
Thank you for the presentation.